So let's talk about the Affordable Care Act, and I kind of akin this to when health maintenance organizations came out. When the HMOs came out, we didn't know anything about a gatekeeper, a referral, pre-authorization, primary care physician. But those are all now very common words for us. They're household names. Well, now we have a whole lot of new definitions. We have the medical loss ratio, employer share responsibility, actuarial value and minimum value, premium subsidies, cost sharing reductions, and the lovely essential health benefits. It's actually the essential health benefits that are causing most of the problems right now for Washington and for the Affordable Care Act, other than the website. And the reason is that in order to have a qualified plan under the Affordable Care Act, it must provide certain essential health benefits. And there can be no annual limits or lifetime limits on those essential health benefits. In addition, there are certain expenses, preventative care, that must be covered first dollar. So you can't even have a copay on it or coinsurance or anything like that. And that includes preventative care, immunizations, annual exams, mammograms, PAPs, all that kind of stuff. So that's what's actually leading to the problem with, if you want to keep your health plan, you can under the Affordable Care Act. Well, guess what? You can't, because the vast majority, as you all know, of individual plans don't have all the essential health benefits. And so that's why we're seeing 300,000 individual plans in Florida being canceled. It's not because the insurance company doesn't want to provide them, it's that they are not qualified plans going forward. So we're going to talk about all the different definitions and their impact on the consumer-directed healthcare. The first is the medical loss ratio. That's actually been around for a little while. It was effective in the beginning of 2012. And what the medical loss ratio is it's the proportion of the premiums that are actually spent on healthcare. Okay? So it requires insurers to pay 80% of the premiums for small group on healthcare, and for large group, 85% of the premiums. If they spend less than 80% for small group, they have to rebate those monies back to the individual through a rebate that usually happens in the fall. We had our second rebates coming out now. First rebates came out last year. The interesting thing about the medical loss ratio is that the calculation is spread across the entire book of business. So in the high deductible plans, you don't tend to spend 80% on health care. You know, the medical loss ratio for high deductibles is maybe in the 60-70% range. But when it's blended with the PPO and HMO products, which are sometimes spending 90-95% of the premium dollars on that, and sometimes over that, it's blended over that, so the rebates have been a little low. The other interesting thing about the MLR is, for actuaries, it's very difficult, because if you don't spend the 80 or 85% of the premiums on healthcare, you have to rebate it. But what happens if you spent 105% of your entire book of business on healthcare because we had a swine flu epidemic or something else? Can you recoup those dollars? No. So it's a one-way street with the MLR, and that is very precarious for the private insurers, and especially the small insurance companies. And that's one of the things we think the MLR might do, is it might cause small insurance companies to go out of business, and we'll just be left with the big boys. What's employer share responsibility? Well, it's going to start January 1st of 2014, right? Wrong. It's actually going to start January 1st of 2015, because there was a delay that came out in late summer. But the employer share responsibility requires employers that have over 50 full-time equivalent employees. So now we have a new word from the ACA. We have an equivalent employee. What's an equivalent employee? Equivalent employee is if you're full-time, which they've now defined as 30 hours per week. Again, they're making up their own rules. So now full-time is 30 hours per week. Part-time is under 30 hours per week. A full-time employee counts as one equivalent. A part-time employee counts as half an equivalent. So if you have 25 full-time employees and you have 50 part-time employees, in essence, you have 50 full-time equivalents, 25 and 25. And you would therefore have to provide a minimum level of coverage to your employees, to your full-time employees. You don't have to provide insurance to the part-time employees, but the part-time employees count on that full-time equivalent. How do you figure that out? Well, you can use the current year numbers to project into the next year. There's lots of complicated issues with the employer share responsibility. And because employers really complained and said, look, we can't figure this out. We don't know how we're going to do this because we have seasonal employees. We have employees that are in different subsidiaries. How does all that work? They've given a one-year reprieve to try and figure that out. In addition to providing health care to their employees, if they're over 50 full-time equivalents, the coverage must be affordable. And what does that mean? It means that the coverage cannot cost the employee more than 9.5% of their annual household income. How many employers know the annual household income of their employees? None. How many are going to get it from them? None. Okay? So they put in a safe harbor which said that as long as it doesn't innocent until proven guilty, we are guilty until proven innocent. So if your employee checks that my coverage was unaffordable, which could mean that they just didn't want to pay it, it wasn't over the 9.5%, you as the employer will get a letter from the IRS, and then you have to go and prove what the cost of their insurance was up against their wages. So the onerous responsibility is on the employer. Another fun thing for employers. We've got to be at the table. So let's quickly talk about actuarial value and minimum value, because I found that a lot of people kind of mess up or mix the two together. Actuarial value and minimum value are the amount of coverage the policy is intended to provide. It's not the amount of money that was actually spent. That's the medical loss ratio. It's that the way the plan is designed, it's intended to provide a certain level of coverage. For actuarial value, that is for small group and individuals. Minimum value is large group. Actuarial value is individuals and small group. So for actuarial value, they put it into different metal levels. They have a 60% metal level, 70 for bronze, 70% silver, 80% gold, and 90% platinum. And when we first did the law, we thought, okay, so bronze will be from 60 to 69.9, and silver will be from 70 to 79.9, and so on and so forth. Well, guess what? That didn't happen. The government said, no, the actual metal level is 60% on the nose. But we'll give you a plus or minus 2% de minimis variation. So bronze is now 58 to 62. So if it's 62.3, it's nothing. It doesn't exist. It doesn't meet a metal level. Correct, because it's not meeting a metal level. So the insurance plan spent all of last year trying to figure out how to get coverage to meet these metal levels. And I'll show you some examples going forward. But that is kind of crazy. Minimum value is 60%, and I'm going to talk about it here on this next slide. What large employers and self-funded thought they were pretty much going to be left alone with the Affordable Care Act. The Affordable Care Act was really for small group and individuals to provide the exchanges, the shop exchange, you know, the individual marketplace and all that kind of stuff. They thought they were going to be okay. Well, guess what? They would have to provide insurance, but that was it. And it would have to meet a minimum value of 60%. Well, that was it. Well, no, it turns out that in addition to the coverage meeting the 60% minimum value calculator, they also capped the out-of-pocket maximums for large group and self-funded plans, which large group and self-funded weren't counting on. And interestingly, the cap is equal to the HSA high deductible out-of-pocket maximums. That's what they're using. So that also was just delayed till 2015, which was interesting. Do you know when they delayed it till 2015? In February of 2013, and none of us knew it. It was buried in a one-line FAQ that they sent out that said that if you have any difficulty, you know, in changing your plan design to meet those out-of-pocket maximums, you can wait till January 1 of 15. A reporter found it sometime over the summer. It was pretty amazing. So, you know, we're finding out what's in the Affordable Care Act. So the out-of-pocket maximums for 14 will be $63.50, $12.7, but again, doesn't really matter. You can have out-of-pocket maximums in large group and self-funded in 2014 above that. There are no deductible limitations in the large group and the self-funded plans. The deductible limitations is small group and shop. Okay? All plans will be subject to the excise Cadillac tax in 2018, and that will be if it's over $10,200 for an individual and $27,500 for now. Any plan, be it self-funded or large group, they must go in, put their plan design into the minimum value calculator, and it has to come out at 60% or higher. It has to meet minimum value, or it's not a qualified plan. So they do have to provide the essential health benefits, but the plan has to meet 60% and up. And it's not the plus or minus 2%, so you can't go down to 58 on the minimum value. That's actuarial value. And we did some calculations, and 99.5% of the plans meet minimum value. So it's not a big deal. And that was before you had to add in some of the additional coverage. So let's quickly talk about premium subsidies. These are available to households below the 400% federal poverty level. And in order to get a subsidy, you have to purchase through the exchange. You can't go out to an insurer directly and qualify for a subsidy. It has to go through the public exchanges. The subsidies are not paid to the individual, they're paid to the insurer, and then the insurer bills the insured for the difference in the premium. So I thought, okay, well, let's go in. These calculators are available all over the web. You can just put in ACA subsidy calculator, and a whole bunch of them come in. So, you enter your income in 2014. You put in, we just put in $51,000 in income. The person's 45 years old, has a family of 4. The employer is not providing coverage. There's a regional cost factor, and that's, you just click on the question box and it'll tell you where you live, if you're in a high cost factor area, low cost factor area, medium cost. So we put it in, we submitted it, and the income was $51,000. They're at 218% of the poverty level, making $51,000 with a family of 4. So they qualify for a subsidy. The health insurance premiums should be around $14,245 for this family. They are going to be required to pay $3,500, and we, the taxpayers, are going to pay the other $10,716. You should go play with this calculator. It's interesting. Cost sharing reductions. This is another thing they added in. These are for households under 250% of federal poverty level. What's the federal poverty level to get into Medicaid across the country? 133%. Some states it was up to 150%. When they talk about the expansion of Medicaid in those states, what they basically did is they just increased the federal poverty level to allow more to qualify. So if you are below 250% of the federal poverty level, you are, in addition to qualifying for a subsidy, your cost sharing goes down. How do they do that? Well, they lower the out-of-pocket maximum first, and then if that doesn't work, they lower deductibles, they lower co-pays, lower co-insurance to meet these new actuarial values. It's very complicated on how it works, but the real interesting thing is that the only way to get a cost-sharing reduction is to buy a silver plan in the exchange. You can't buy a gold, you can't buy a platinum, you can't even buy a bronze. Why is that? Don't know. How many people do you think are going to get cost-sharing reductions? Out of the 6, probably 1. I don't know. So what are the types of exchanges? We have a bunch of different exchanges right now. We have the individual public exchange, now called the marketplace. We have the shop exchange, and I always thought, what did SHOP stand for? And then I found out Small Business Health Options Program. It should be the SHBOP, but it's not. And it's small health options programs. And then, of course, we have the private exchanges. So what's going on with the public exchanges? Well, public exchanges are the ones where you get the subsidies, cost-sharing subsidies. I love this slide. They were expected to be operational in all 50 states by 1/1. We'll see. And open enrollment began 10/1, as we all know. And they're not having any issues. There are 16 state-based exchanges, i.e. the states decide to run their own exchange. And those actually are the most successful so far. There's 26 federally facilitated exchanges. We have one in Pennsylvania where I'm from, And I haven't heard a single thing, not an advertisement, not how do I get there, where do I go. Everybody just has to kind of find it. And then there's 8 partnership exchanges. Most of the health plans are offering the HSA qualified plans on the exchange, but we found out in New York, the insurance companies didn't bother to put a single HSA qualified plan on the exchange, not one. In California, they announced that there were no HSA qualified plans on the exchange, and it turns out there's 23. They didn't know what was going on. The shop exchange is a non-subsidized for small group. I mean, the shop exchange is just, we're not hearing anything about it, so we're not even going to talk about it right now. Where we're seeing a lot of action is in private exchanges, and there's a number of different private exchanges going on. There are defined contribution strategies for large employers. They're being run by Mercer, Towers Watson, Aon, the consulting firms who usually work with those entities. We have a number of health plan partnerships that, like Aetna calls theirs Liaison, the Blues call it Bloom, Regions calls it Taylorwell, Allcare, a small insurance company in Ohio, has one called Connected Care. We're not sure how these defined contributions are going to work under the Affordable Care Act, but what we are seeing is that in the private exchanges, what they're selling is almost all HSA qualified plans. It's dominating that marketplace. So what really happened with the Affordable Care Act when it was passed? What was the true impact on consumer-directed health care? Well, for flexible spending accounts, or FSAs, the limit was dropped to $2,500. Although something just happened last week. We'll talk about that. And you can't use those funds for over-the-counter medication. Now, they're going to index the $2,500 to the cost of inflation or cost of living increases going forward. And so everybody wanted to know, is in 2014, is that $2,500 going up? No. Inflation, cost of living was low enough that it's going to stay at $2,500. So that was the only impact on flexible spending accounts, was limiting $2,500 and can't use it for over-the-counter medications. What about HRAs? Well, it took a while. We didn't know what was going on with HRAs, and then we just started to get the guidance over the last 2 months. And basically for HRAs, it's not as good as it is for FSAs and for HSAs. It's much more onerous. Why? Because they look at HRAs as a health plan, a qualified health plan. So an HRA cannot have annual and lifetime limits on essential health benefits, but all HRAs are set up that way. You know, the employer says, I'm going to give you X amount of money to use for your health care, and after that, you're responsible, right? That's how an HRA works. That's not allowed. So standalone HRAs have been wiped out. And so the only way to have an HRA is to, they call the word integrated, but when I use that word, most people don't know what that means. What it means is it has to be attached to a qualified health plan. So you can have an HRA with a qualified health plan, but that's it. Other than they are allowing retiree-only HRAs to help them pay for premiums, things like that, but employers who want to put monies into an HRA for their employees' premiums cannot do that. You're going to have to basically bonus them the monies that you were going to give them. They pay tax, and then they use those monies to pay for their premiums in the exchange or whatever. There are things called HRA credits, which could be rolled over, but it's really a pain in the neck. And you cannot, this got Zane Benefits and a couple other companies very upset, you cannot use an HRA for your employees who purchase individual coverage. Disallowed. So there was some significant changes to HRAs, not good ones. It's going to be difficult. And just add insult to injury, they added additional fees called the PCORI fee, okay, which is the Patient Center Outcomes Research Institute fee. I don't know what the heck they do. But, you know, they're going to tack on an extra $1 per employee for plans that started before October 1st of 13. And now it's $2 per employee. It's paid by the health plan or by the self-funded plan sponsors. So that's just going to raise premiums. Who doesn't have to pay the fee? FSA plans, wellness programs, supplemental plans, HSA plans. It is deductible as a business expense, but it's just one more tax and fee. So quickly, what were the HSA changes? Well, when we saw the Affordable Care Act come out, we were extraordinarily concerned that HSAs were going to be wiped out, that they were not designed to meet 80% MLR and so on and so forth. But in truth, the only thing that really happened right off the get-go was 2 legislative changes. Just like FSAs, you no longer could use your HSA funds to pay for over-the-counter expenses, and they changed the penalty for non-qualified withdrawals from your account from 10% to 20%. Well, you can still, your members can still use their HSA funds to pay for over-the-counter medications if their doctor prescribes it. That's true for both the FSA and the HSA. You just need a prescription. And quite frankly, we don't want individuals taking out non-qualified funds, so the penalty wasn't attached to a medical plan. But there were a lot of threats. Okay, there were only 2 things that really happened to HSAs, but there were a lot of threats. The medical loss ratio had us really concerned because we knew HSAs weren't going to meet the 80 and 85%. But currently, there's no impact because, as I said, the medical loss ratio is blended over the insurer's entire book of business. However, as the HSA qualified plans become a larger percentage of that, MLR may become a factor in the future. Cost sharing reductions, also an issue. If you qualify for cost sharing reductions, it's going to probably change the deductible or the out-of-pocket maximum to non-HSA qualified. Individuals can decline the cost sharing so they can have their HSA account. How likely is that going to happen? They're already below the 250% of federal. I don't even know why we're talking about that. So our HSAs, HSA safe? Absolutely. What we did is we took the highest deductible HSA qualified plans and we threw them in the minimum value calculator and the actuarial value calculator, and guess what? They hit bronze and 60 right on the nose. Now, one could argue, because when we talked to insurance companies, there was no way a $6,350 deductible was meeting 60% actuarial value 2 years ago. But magically, the calculator makes it work. And that's without employer contributions. The ACA is also now using HSA qualified out-of-pocket maximums for their rules and regs. And the other concern we had was, could you combine an HSA with incentive programs and wellness programs and still be ACA safe? And the answer is yes. So you have all seen this slide. The only reason I show you this slide is to make one point and one point only. When I started first MSA in 1999, if we had made everybody go into a medical savings account at that time, we would be in 2012 at our premiums would have increased 38% and they would have been equal to what the wages went up. Would we even have an Affordable Care Act? No. So because we've been in very high cost plans with no consumerism, that's what happened. And that gap right there is why we're having this debate today. Employers are expecting cost increases. I'm not going to go into this other than to say the impact to different employers depends on whether they've traditionally given good quality plans or whether they've traditionally not provided plans. If they haven't provided plans, now in the Affordable Care Act, their expenses are going to go up. So retail, hospitality, that kind of stuff are expecting much bigger cost increases than the federal government. What are we seeing out there in the marketplace? I talked to a couple individuals out in the hall about this. Large employers, which for this study, used to be large employers were 100 or above. Now for the Affordable Care Act, it's above 50. But large employers in this study was 100 or above. What we've seen is that they are embracing HRAs and HSAs to the max. And in addition, we're seeing 100% enrollment in 14.5% of large employers. They're just going full replace. We're seeing that 8 out of 10 are actually offering CDH plans and more plan to do that this year. So how are employers going to react for this? Are they going to pay, play, or neither? What do you mean by neither, Bill? Well, for small employers, they don't have to do anything, right? I mean, they don't have to provide insurance. They're under 50 full-time equivalents. So they didn't know what to do between 2010 and 2012. But now they're predicting in 2014 that up to 50% are going to drop their plans next year. Large employers, again, they didn't know what the regs were going to be on them. it's still staying around 7% to 10% think that they are going to drop. And I think for large employers, when you're talking large employers, you're talking the 50 to 200 space. You're not talking larger than that. The other thing we're seeing is employers reacting differently. We're starting to see restaurants hiring and other industries hiring differently. They're hiring all employees to work 29 hours or below. They're part-time. So what's this going to do to a lot of people out there? Well, they're going to have 2 part-time jobs. Where they used to have a full-time job that didn't provide them health care, but at least they worked at the same place and got the other stuff they wanted to do. A lot of employers aren't going to allow that, so they're going to have 2. The penalty is not more expensive than the current cost, so a lot of them may just dump to the exchange. It just depends on that. The other thing we weren't sure of is calculation of the actuarial value, and this is your question, Justin, because we had this come up here in Tennessee, is that the actuarial value for the bronze, silver, gold, so on, needs to be calculated by the health plan. When the IRS said it was the health plan's responsibility and not the employer's responsibility, it meant that the health plan now had to design a plan that met bronze, silver, gold, or platinum. And that could be with or without HSA or first dollar available HRA contributions. So one of the questions became, if you have an HSA qualified plan that is already in the bronze level, an employer comes in and says, well, I'm going to put in $750 into that. And it takes it from an actuarial value of 61 to 65% because they're putting in that contribution. Does that make it not qualified anymore? Because now it's not bronze. The answer is no, because the law stated you may use HSA employer contributions to meet a certain bronze level, but it didn't say you had to. Okay? So by the insurance companies having to are responsible for that, they put the plan designs in to meet that, so once it meets that, it's bronze forever, regardless of what the employer does. The deductible limitations for the shop exchange are another issue. I know that was very big here when I was in Tennessee a few months back. And the questions are, can we raise the deductibles? Or the word was, can we buy down the deductible to $2,000 and $4,000 by employer HSA contributions, first dollar available HRA funds? The answer is no. You cannot buy down to the deductible. Now, the law actually states that you can buy down to the deductible for using flexible spending account funds. But when the guidance came out, guess what they did? They didn't mention anything about using flexible spending account funds to buy down the deductible. So we at the ABA HSA Council have gone back to them and said, the law says we can do this. Can we do it? They go, we're not sure. So we're waiting for an FAQ and some guidance. And this is the major problem. We are in November. We're out selling plans, and we have no clue whether what we're selling is ACA safe or not, because they won't tell us what the rules are. So that's why I put up questionable FSA. I don't know. You probably can get away with it because the law says it. And we believe that the law is paramount to them. You can't make a reg that goes against the law. Until last week, then you could. But the other thing you can do to meet bronze level, you are allowed to raise the deductibles above the $2,000, $4,000. How do you do that? Well, I went into the actuarial value calculator to see how it works. And I put in a deductible, this is a single deductible, of $5,200 with an out-of-pocket max of $6,350, doing 100% co-insurance. And guess what? It came out to bronze. So that means a $2,000 deductible with a $6,350 out-of-pocket max doesn't meet bronze. It can't. And so I went to try and figure out what is the lowest deductible I can get to get just outside of bronze. And it turns out it's $3,750. So the $2,000, $4,000 doesn't really matter. You're going to be able to, in the small group market, continue to have deductibles that are higher than that because that's the only way they can meet bronze level. So higher deductibles are safe. Again, we talked about this. What are employers going to do? Well, it depends. I mean, your employees, based on your demographics, may be better off in the exchange than actually you providing them a group plan that costs them more. Depends on the demographics. Each employer is going to have to look at that. But there's, as we know, a lot of education resources that need to be put together to manage this stuff, and nobody can get into the exchanges and whatever. So business as usual is probably what's going to happen for this next year, especially because we still have a 1-year delay. They're going to have one more year to figure out what the heck they're going to do. But how can employers bend the cost curve? I love this slide. It depends on your adoption of consumer-directed healthcare. The more employees you have in a CDH plan, the better cost savings you're going to get. And so this slide shows that if you increase from 25% to 75% adoption of HSAs, you go from literally a 2% reduction in cost to a 9% reduction in cost. That's significant. And there's a little caveat down here that says that if 1/2 of people in employer plans would choose the HSA qualified plan, we'd save $57 billion annually in healthcare expenses. It's pretty powerful stuff. Another question I always get is, which is better for cost savings, an HRA or an HSA? Well, it turns out both are good at changing the spend curve, but HRAs decrease. This is the American Academy of Actuaries study. HRAs drop your costs 4 to 6% in the first year. HSAs are 10 to 12% in the first year. And if you do a full replace HSA strategy, you're looking at 17% reduction in costs. And these savings have now been sustained over the years. So what we're seeing is a lot of companies, self-funded specifically, a large group, are going full replace strategies. They're coming out with a dual option 1 year with a plan to go full replace the next year. And that's going to be important to avoid what? The excise tax. Because if your premiums are going up nationally 8.2%, eventually you're going to hit the Cadillac tax. You all know this. The only point I want to make about this is that the HSAs, in addition to driving behavior change, they don't drive behavior change if they don't have the account. So they do a lot better, more cost savings and stuff if they have the account. If they don't, they spend more. We're seeing significant CDH adoption, as I said, and a lot going to total replacement to avoid the excise tax going forward. How do you increase adoption as an employer? One of the problems I've seen is in plan designs. When employers are offering dual options, they'll oftentimes have a $500 deductible PPO plan with an out-of-pocket maximum of $2,000, and then they'll have a $2,000 or $1,500 deductible HSA qualified, but they do a $6,350 out-of-pocket max. When an employee looks at an out-of-pocket maximum of $2,000 versus $6,350, it doesn't matter if they're financially better off in the HSA plan, premiums and everything else. They just are scared of that out-of-pocket maximum, and they're not going to choose it. And you know, we want to see employers take their premium savings by going to the high deductible and putting that in as an account contribution to offset the deductible difference. If you do that, it's a no-brainer to go into the HSA qualified plan. You should consider full replacement. Why? Because of the cost savings on the previous slide we just talked about. But it's all about education, education, education. So what's going on out there? I found this slide interesting. This is AHIP's most recent slide. And for HSAs, look at the individual market. It's stagnant or going backwards. See that? Smaller shift. Small group, pretty much stagnant. Where are we seeing all the growth in HSAs? Large group. And we're seeing that at Health Equity. We've brought in 4 companies with over 60,000 employees in the last 3 weeks. So we're seeing significant adoption of HSA plans in the large and jumbo market. Tennessee's doing pretty good. You guys got a lot of HSA qualified plans. You're in the 270 and above. So how is the Affordable Care Act doing? Well, it's doing pretty good. It started October 1st. They had a technical surge. That's another new term that came out. Anybody ever heard of a technical surge before? It was because so many people hit the site. And, you know, I think a lot of people did hit the site, but they were all reporters, insurance agents, and all of us trying to figure out, policy wonks trying to figure out, does this thing really work and what does it look like? And we basically shut it down. The technical problems will get fixed, but not by November 1st. They don't have a chance. They have so many problems and so many untested things that it's going to take a year or longer for them to get the bugs out of the system. November 31st is when they said they would have it up and fixed. By November 30th. Yeah, we're after November 1st. In Vermont, they have their own state exchange. They just shut it down last week. Why? Because they're having glitches as well. It wasn't ready. So in Vermont, you could go in and you could actually see your plans, but you couldn't purchase your plan. And Vermont is requiring everybody to go through the exchange to purchase their plans. You're not allowed to go directly to your insurance company anymore. The state of Vermont says you must use the exchange to purchase your health insurance, and they can't purchase their health insurance because the exchange doesn't work. So it's delayed till magically when? March 31st, which is the delay for enrollment of the public exchanges, but again, we'll see. New York State is another interesting exchange. To get into the New York State exchange, before you get any information, you have to give your name, your address, your date of birth, your social security number, your income, your county that you live in, and so on. And then it will let you go in and view the rates and the products that are available. Security is a major issue here. Major issue. What's the best state exchange? You know, they made fun on that video that the public exchanges sold 6 HSAs. We think are 6 qualified plans in the exchange. We think 1 was sold in Delaware. We're not sure. But for Washington State, they have a state-run exchange, and they're doing pretty darn well. As of 2 weeks ago, they had 36,000 enrolled already. But what was interesting is when we looked at who was enrolling, 35,000 of them went into Medicaid. They were below the 133% of poverty level. They already qualified for Medicaid. They just thought they could go in and get a subsidy, and magically now they're enrolled. You know, so the other 1,000, pretty much the high-risk pool for Regents and everybody is in that 1,000 right there. The shop exchange, all I can say is anyone going? No. Are we going to see an individual mandate delay? As of April of last year, it was 50-50. Then in the summertime, it was 70-30 we were going to see a delay because the employer got a delay, so we would naturally assume the individual was going to get a delay. Well, that didn't happen. And when it went live October 1st, so on September 30th, it was felt there was 0 chance of an individual mandate delay. On October 5th, it was back to 50-50, and now it's almost 90% likely that we're going to see an individual mandate delay. Why? Because you can't purchase the insurance. You're not going to be able to purchase insurance. And how many of the young invincibles that they say they need to fund this have gone in and even looked at the exchange? Pretty much 0. You know, pretty much 0. So the other fun thing is this is kind of interesting. I found this out. This is on the healthcare.gov website. These are the hardship exemptions that even if the individual mandate still is there, you may qualify for an exemption called a hardship exemption. Well, you look at them, you know, if you're homeless, you qualify. If you were evicted in the past 6 months or have been facing eviction or foreclosure, you have an exemption. If you recently received a shutoff notice from a utility company, you get an exemption. If you experienced domestic violence, if you recently experienced the death of a close family member, I'm now left off. I lost my mother-in-law the end of September, unfortunately. If you experienced a fire, flood, or other natural human-caused disaster. So when they were working in my house, they ruptured my sewer pipe, so I guess I'm off again for that one. You filed for bankruptcy in the last 6 months. This I love. You didn't pay a medical expense in the last 24 months. Well, me being a doctor, that happens every day. So, you know, I think most everybody qualifies. And then you experience unexpected increases in expenses due to caring for somebody who is ill, disabled, or an aging family member. We're all seeing the baby boomers age. Pretty much everyone qualifies. The long and short of it is we think they're going to add one more to this list very shortly. It's going to say, if you've ever had any trouble logging on to healthcare.gov, you get an exemption. So what do you guys do out here? You know, how are you going to survive and hopefully thrive? You have to become trusted advisors to your employers, to your book of business. You have to become a trusted advisor. What does that mean? It means you can't come in anymore and just say, here's the premium, for next year, let's have it. You have to sit there and talk to them about strategies to avoid unaffordable insurance, to avoid the Cadillac tax, to avoid constant increased costs, to simplify the plans. It's getting much, much more complicated. And they're going to look to you as the trusted advisor, and you have to help them through that. For a large group, I really believe they're all moving to CDH strategy. You as their advisor have got to move them into CDH, be it the HSA or the integrated HRA, because they are lower cost and they have higher satisfaction. And I strongly would recommend full replace this dual option, tri option, quad option anymore. Think of how you're going to calculate the excise tax in 2018 across all that stuff, and the affordability at 9.5%. Make it simple. One plan. For small group, again, it depends. You may be advising them to say, hey, you're better off paying the penalty and sending them the exchange if it's up and running. But, you're just going to have to see because of subsidies. Quickly about Health Equity, we were founded in 2002. We're in Salt Lake City. We are the fastest growing HSA, FSA, and HRA administrator in the country. We have 1.3, we're actually 1.4 billion in assets. We're up to 1 million accounts, which is about 800,000 HSAs and 200,000 HRAs and FSAs. We have over 20,000 employer relationships, and we are integrated with 63 health plans, which means that we get claims and eligibility from 63 health plans across the country, and we will be adding a huge health plan for next year. It's a big nationwide blues, so I'm going to say. We have small clients that have had great success, such as American Express, Google, General Dynamics, Boeing, and so on. We provide a complete platform for your clients. We provide HSA, HRA, FSA. We have investment options. We provide financial advisors for the investments. We have prescription savings plans. We provide online free bill payment, wellness and incentives. We will run wellness and incentive programs for your employers if you want to do that. And we just added a really cool mobile app. Our mobile app was actually started by Cheesecake Factory. When we got Cheesecake Factory, they said, look, all of our employees don't want to go and use a laptop or even an iPad. They're on their phone. And so they said, we want everything that you do on your website on that app. And so on that app, you can check your balance, you can move monies back and forth, you can pay a provider. But what's really cool is you can take a picture of an expense and it will upload into your HSA and be adjudicated.